Now, today we will try to focus our discussion on Porto-Systemic Encephalopathy. Okay?
Okay, sir.
Porto-Systemic Encephalopathy is an essay question for you. No doubt about that. Time and again, Porto-Systemic Encephalopathy will be asked. Okay? So I'll make some questions and probably you will try to answer those things. PSE, Porto-Systemic Encephalopathy, also called as hepatic encephalopathy. HE is a neuropsychiatric syndrome associated with hepatocellular failure or portosystemic venous shunting. You can write down if you want some of the points which I am saying. So the definition of the hepatic encephalopathy is either it is PSE with portosystemic venous shunting, or it is hepatic encephalopathy with neuropsychiatric syndromes in the absence of portosystemic connection. There has been a lack of standardization in the terminology, and we used to call it as acute encephalopathy and chronic encephalopathy previously. And in 2002, a working committee, a task force on hepatic encephalopathy has been appointed, and they standardized the definition of hepatic encephalopathy. Okay. Now, according to the characteristic neurological manifestations, hepatic encephalopathy is now characterized as 1. Episodic, 2. Persistent, 3. Minimal. Episodic, persistent, and minimal. Episodic means previously it was acute. Because there is an episode of acute encephalopathy, it was called acute in those days. Today we don't use the term acute and chronic. We use called episodic. Persistent means chronic, and minimal previously called subclinical. You can write in brackets episodic, previous terminology acute, persistent, previous terminology chronic, minimal, previous terminology subclinical. Now acute, chronic and subclinical are replaced now, and we use only the new terminology, which is episodic, chronic, minimal. Now it is also classified on the state of the liver. Based on the state of the liver, it is classified as type A, B and C. The first classification is based on the presentation, which is episodic, chronic, minimal. Based on the disease state of the liver, how decompensated is the liver, we call it as A, B and C. Encephalopathy associated with acute liver failure, that is type A. B. Encephalopathy associated with portosystemic bypass. Okay, that means the liver is bypassed and there is a regular shunting of the portal blood into the systemic thing. And there may be no intrinsic hepatocellular disease. There could be some other reason for portosystemic bypass, either an iatrogenic shunt or anything. That is called hepatic encephalopathy type B. Type C, hepatic encephalopathy associated with cirrhosis and portal hypertension and portosystemic shunting. Now you understand? Type A encephalopathy is acute liver failure and encephalopathy. Type B encephalopathy, liver is normal, but only the bypass is there. Type C, there is liver involvement, there is cirrhosis, there is portal hypertension, there is portosystemic shunting, and then encephalopathy. Okay. So these are the two types of classifications. Another thing is, why do I recognize this syndrome? Because it is a reversible condition. It is a reversible metabolic encephalopathy with multifactorial pathogenesis. Causes are many, multifactorial, and you can always reverse the encephalopathy in this particular condition. Okay?
Okay, sir.
Now, what is the reason? Pathophysiology. What is happening? Normally, the intestinal, gastrointestinal food and nutrients and toxins are absorbed from the GI tract and fed to the liver, where detoxification occurs and all toxic metabolites are excreted into the biliary tract, and a purified non-toxic blood is fed into the hepatic vein. Last time we saw the hepatic circulation, porto-hepatic connections and portal circulation, and the purified blood goes into the inferior vena cava through the hepatic vein, right and left hepatic veins, and all the toxins and waste, nitrogenous end products are shunted into the biliary tract and then excreted. In this particular condition, what happens? There is excessive formation of ammonia in the GI tract, and this ammonia is absorbed through the portal circulation, and part of it is detoxified in the liver, and liver is overwhelmed, not able to detoxify. Ammonia spills over into the systemic circulation, or there could be porto-systemic bypasses. Already the channels are there through which the ammonia bypasses liver and directly enters into the systemic circuit. Ammonia is the prototype of the toxin. Is it the only toxin? No, there are other toxins also. Hyperammonemia, porto-systemic shunting was the hypothesis right from 1877 onwards. So there is enteric production of ammonia is more. Liver is overwhelmed, not able to detoxify the ammonia, or it is bypassed through the shunts, to the portosystemic shunt. Okay, portosystemic shunting is a requisite for the development of portosystemic encephalopathy. Although disturbances in urea cycle metabolism may also cause hyperammonia, and encephalopathy does not occur in isolated hyperammonia in the presence of a good liver. For example, let us say there is bleeding from the gastric ulcer into the GI tract. That blood is decomposed by the intestinal bacteria. Ammonia is produced, but liver is normal. He will not develop encephalopathy because it will take care. In the patient who has a compromised liver, hyperammonia will enter into the systemic circulation. Okay.
Yes, sir.
There is also intrahepatic shunting also connected. Intrahepatic shunting means transjugular intrahepatic portosystemic shunts. This is called the TIPS. What we do, we will place a shunt between the portal vein and the hepatic vein and try to bypass the liver as it is not properly functioning, and to avoid variceal bleeding. This is a treatment. TIPS, transjugular intrahepatic portosystemic shunting. This provides a conduit for the portal venous blood to flow directly into the hepatic vein and then on into the systemic circuit, bypassing the liver parenchyma. This TIPS is done as a treatment for the variceal bleeding, and TIPS is associated with the development of PSE in about 1/4 of the patients. A patient who undergoes TIPS, he is at a risk of encephalopathy because intestinal toxins, particularly ammonia, is directly channeled through the shunt we have created into the systemic circuit, and 1/4 of the patients can develop these things. So there are other toxins which are also made responsible or made culprits for hepatic encephalopathy. For example, phenols, thiols, SCA fatty acids, SC fatty acids, short chain fatty acids, phenols, thiols, short chain fatty acids, and other mediators of cytokines and bacterial toxins. Okay. The main culprit is ammonia. The associated culprits are phenols, thiols, short chain fatty acids, cytokines, bacterial toxins. And also there is an enteral production of gamma aminobutyric acid, and endogenous benzodiazepines are produced. Just like you take Valium tablet, a benzodiazepine, benzodiazepines are produced in the gut due to the liver failure. And these are somewhat speculative. Whether the gamma aminobutyric acid and endogenous BZPs are there, some evidence is there, but not very firm. But we clearly know ammonia is one major culprit. Phenols, thiols, short chain fatty acids, cytokines, and endotoxins are also responsible. The thiols are also called the mercaptons. These mercaptons are very volatile molecules. That means though they are in the liquid form in the body, they get converted into gases and they get excreted through the lung. And the common cause of fetor hepaticus is the fecal smell of the mercaptons. If somebody asks you what is the cause of pungent odor, it is due to the sulfhydryl groups present in the mercaptons. And sulfur, as you know, produces a sort of fetor hepaticus like. So the cause of hepatic fetor hepaticus or the odor in a patient is not ammonia, it is mercaptan. Okay. And hyperammonia will lead to ammonia excretion in the urine, and urine will be more ammonical in urine. Already urine is ammonical in water and much more in that. Okay. So now why we are interested in that? If ammonia is the culprit, we will try to reduce the production of ammonia and we'll try to metabolize the ammonia in a different mechanism and we will try to reduce the toxicity. So treatment dependent. How do I reduce the ammonogenic luminal bacteria are suppressed by using gut antibiotic like rifagut, you know, or neomycin or any enteric locally acting antibiotics which are not systematically absorbed. Okay, they can be used to decrease the production of enteric ammonia by the bacteria. Or we can use ammonia, we can use luminal acidification with non-absorbable sugars. Non-absorbable sugars like lactulose. Lactulose is a non-absorbable sugar and this is fermented by luminal bacteria and non-absorbable sugars are used and the luminal bacteria will act on this and don't produce ammonia from the protein plate. So we try to help the luminal acidification by lactulose. And third, we do not allow the fecal matter to stay longer in the intestine to avoid absorption. By that, we give them laxatives and then produce and relieve the constipation. Okay. And fourthly, we try to reduce the substrate for ammonia. What is the substrate? Protein is the substrate. So protein restricted diet. So when I know the pathogenesis that it's through the ammonia, I have four mechanisms of deammonizing the body. One, reduce the intestinal gut flora activity by giving locally antibiotic and antibiotics like rifixin or neomycin to reduce it. Number two, use luminal acidifying agents, non-absorbable uh, sugars like lactulose. Three, avoid constipation and stasis of ammonical products in the GI tract. Number four, reduce the substrate for the formation of ammonia by protein, restricting the protein-rich diet. This is if you are sure that ammonia is the culprit. Yes, it is in majority of the cases, but we know there are other non-ammonical culprits like the thiols, the phenols, the short chain fatty acids, and those things. So this is a treatment-based pathogenesis. Pathogenesis should lead to treatment. Why? What happens? Let the ammonia go into the body, and what is the problem? Yeah, there is a problem. The production of ammonia and bacterial expression of urease, an enzyme which forms the ammonia from urea. The metabolism of colonic proteins accounts for most of the ammoniogenesis. The bulk of the extracolonic ammonia production occurs in the kidney. Renal failure may promote further ammonia accumulation in the body. Okay. Renal failure may also contribute for the hyperammonia other than the gut. Now, ammonia is a neurotoxic compound. Ammonia is not a simple thing. It is a neurotoxic compound and principally eliminated in the humans by hepatic conversion to urea. Okay. Normally also ammonia is formed. Why we are not getting hepatic encephalopathy? Because whatever ammonia is formed is converted into urea in the liver. In our friend here, the ability of the liver to function normally and convert the ammonia to urea is rather subnormal or missing because of the hepatocyte injury. Okay. Consequently, what will happen? The urea, ammonia is not converted into urea, and urea is normally metabolized, produced in the liver and excreted in the urine. So urea excretion in the urine is reduced because formation is reduced. Okay. Now, besides causing the functional changes, what are the functional changes ammonia causes? Reduces the cerebral blood perfusion. 2. Responsible for structural changes in the brains of the patients. Okay. What is the structural change? The brains of chronic cirrhotic patients exhibit type 2 astrocytosis. Alzheimer type 2 astrocytosis characterized by swollen astrocytes with enlarged nuclei and chromatin displaced to the perimeter or periphery of the cell type. Type 2 astrocytosis is known to cause in part is to be caused in part by the detoxification of ammonia. Astrocytes, the only cell in the brain that can metabolize ammonia to glutamine. You see now, excess ammonia increases cerebral perfusion. Number 2, there is astrocytopathy. That means the normal astrocytes are converted into type 2 astrocytes. Type 2 astrocytes cannot detoxify the ammonia. Normally, the astrocytes which are present in the brain, they can take up the ammonia and convert into glutamine. Type 2 astrocytes are so conditioned that they are not able to do that function, and that results in presence of excessive ammonia in that. So this is the pathogenesis. Now you understand?
Yes, sir.
Yeah. Now, what is the etiology? What is the etiology? What causes photosystemic encephalopathy? Excessive protein intake, which results in ammonia genesis. Increased substrate is available, urea is available for ammonia genesis. This gastrointestinal bleed, blood contains proteins that can constipation, stasis, more absorption of ammonia. Dehydration, again, the dehydrated state, there is a relative excess of ammonia in the blood. And renal failure, clearance of ammonia through the kidney is not happening, and stasis of ammonia in the blood. And on top of that, there is catabolism of the proteins in the system itself, in the liver itself, due to a dysfunction that can, and any infection pushes the stress more on the system, on the liver, and hyperammonia results. Hypokalemia is also associated with hyperammonia and sepsis of any cause. Now, what are all the factors which increase ammonia? 1, increased substrate protein. 2, increased urea. 3, GI bleed. 4, constipation. 5, dehydration. 6, renal handling is at fault, renal failure. 7, increased catabolism of intrahepatic, increased catabolism of the proteins. 8, infection. 9, sepsis. 10, hypokalemia. These are the causes of increased ammonia genesis. We knew now what ammonia causes, and we also know what are the causes of hyperammonia. Now, decreased hepatic function is also a culprit. What is this decreased hepatic function? Dehydration, hypotension, sepsis, hypoxia, anemia, and also liver cell failure due to alcohol, liver disease, your viruses, drug toxicity, all these things will also compromise the liver function. Now, what is it? Is shunting the blood into the portal system, from the portal into the caval, into the vena cava. That is the one which is causing all my cerebral problems. One, there could be portal vein thrombosis in the absence of liver. We have seen last time non-cirrhotic portal hypertension, or transjugular intrahepatic portosystemic shunt, iatrogenically performed, also can shunt the blood from the portal system into the hepatic vein and thence into the inferior vena cava. Spontaneous shunt formation, like the varices themselves act as a shunt. That is the spontaneous shunt formation. Sometimes when you use drugs which they can also increase the porto-systemic encephalopathy. Already cerebral metabolism is depressed, cerebral perfusion is depressed, astrocyte function is depressed. They are not able to clear the ammonia and make it into glutamine, excess ammonia. In such a condition, ethanol, binge drinking, benzodiazepines, anti-nauseants, antihistaminics, these can further aggravate the encephalopathy. Now you have now known the etiological factors for ammoniogenesis, etiological factors for liver dysfunction, etiological factors for post-portocaval shunting, aggravating factors of drugs. All these are important. Okay. Now,
Yes,
what
sir.
is the prognosis of this fellow? What will happen to him?
Sir, we calculated the MELD score, sir.
MELD score and child-Q score.
Child bug score, and we found out MELD score was 18 points, sir.
Hmm.
And child bug score was 28 points, sir.
Yeah.
28 points.
Which puts the patient in what category?
Class C, sir.
Yeah. Now, what are the clinical manifestations? As a clinician, I am interested in that. Are there any neurological features? Are there any features of liver disease? Are there any features of portal hypertension? These are and general features like fatigue, daytime somnolence, nighttime no sleep, vague complaints like tiredness, and family members will say the altered behavior, restlessness, episodic confusions, or the history. Neurological features like daytime somnolence and daytime irritability, nighttime no sleep, fatigue, asthenia, altered mentation, somnolence, and then episodic confusion, restlessness in the night, particularly, are one aspect. Neurological features, there are no specific neurological signs like a cerebrovascular accident or a tumor or a cerebral bleed. That also you have to exclude. Absence of specific neurological signs. You said there is no focal neurological deficiency. That has to be accepted. And three, clinical history of chronic liver disease and the factors which can cause chronic liver disease, like alcoholism, non-alcoholic steatohepatitis, or drugs, or sometimes the viral infections producing the hepatic decompensation. Precipitating causes can be identified, which we have discussed in the previous 5 minutes, and predisposing causes for the development of portoencephalopathy also we have discussed. Okay.
Okay, sir.
Now, what are the clinical features? History is done. Clinical features. As with many toxic metabolic encephalopathies, mental status, in particular, the level of consciousness, is not uniform. It fluctuates. Sometimes he is quite okay. Sometimes he is comatose or stuporose or disoriented. This fluctuating level of mental consciousness is a feature of metabolic encephalopathy. Unlike vascular encephalopathy or unlike tumors, which there won't be fluctuating thing. Here, in case of metabolic encephalopathy, the fluctuating consciousness, fluctuating mental condition is a feature. Here also it is a feature. Okay, patient with Portocan may demonstrate a variety of neurological signs together or in isolation. We said there is subclinical, there is grade 1, grade 2, and grade 4, 3 and 4. There are 4 levels are identified clinically. Subclinical, grade 1, grade 2, grade 3, and grade 4. I'll tell you what are those. Subclinical is early in the course of this, that not much of neurological features are there, and only thing is these can be detected by psychosomatic testing. Clinically, when you examine, you may not have, but if you ask him to undergo some psychometric testings, there are classical structure testings, they will be lagging compared to a normal individual. Okay. Type 1 or grade 1 is with deterioration to grade 1 PSA, PSE, that is Porto-Systemic Encephalopathy. Patients have difficulty in memory, mild confusion, agitation, irritability, and restlessness or sleeplessness during the day, remaining awake at the night, tremor, rhythmic regular oscillations of the body and the hands, incoordination may be seen. If you ask him to write, he will not be able to write properly. There is constructional apraxia. What is constructional apraxia? Ask him to draw a 5-pointed star.
Blocks. Yes,
He will
sir.
not be able to do that. Okay. Ask him to draw a little complex diagram. He will not be able to draw that. That is grade 1. Grade 2 PSE involves showing of mentation and slowing of the speech and appearance of lethargy, and confusion continues to be there. Now asterixis may be there. Flapping tremor, irregular flapping tremor may be observed, as we have already said, when the wrists are dorsiflexed and fingers spread out, the elbow extended and shoulder abducted, dorsiflexed at the wrist and fingers fanned or spread out. There may be dysarthria. Patient, you ask him to walk as though he's a drunken fellow, he will be ataxic in walk, and all these are due to the cerebral involvement, and the inhibition is lost. And at this stage, the inhibition is somewhat there. That is where deep tendon reflexes are hypoactive. Stage 2. Stage 3, further worsening of the mentation. Typical asterixis, deep tendon reflexes are now exaggerated. Babinski may be positive because the inhibitory component of the extrapyramidal is removed. Only just like a pyramidal lesion, only the inhibitory component is removed, and hyperreflexia and Babinski may be positive. That is stage 3 or grade 3. Grade 4 is frank hepatic coma, and it is a medical emergency, and he requires intubation and ventilation because his respiration is not under his control and erratic. And stigmata of chronic liver disease and portal hypertension may be available on examination. Just as you said, gynecomastia, testicular atrophy, palmar erythema, spider nevi, splenomegaly, caput medusae, ascites, peripheral edema, shrunken liver, all these things may be there. More specific signs of other liver diseases like Wilson's disease, cave ring may be there. If it is hemochromatosis, bronze colored skin and arthropathy may be there. If it is due to excess cholesterol in the system due to poor liver function, there could be xanthelasma and primary biliary cirrhosis. Alcoholic liver disease accompanied by malnutrition in general, and he will have features of long-standing liver disease with shoulder girdle and temporal muscles and hip girdle wasting can be seen in alcoholic malnutrition. And if it is hepatitis C, you will have some of the cutaneous features of vasculitis and some cryoglobulinemia and porphyria. All these things can happen if there is associated viral liver disease. What are the differential diagnoses?
Sir, alcoholic hepatitis.
The differential diagnosis of a person with coma, structural central nervous system disease. Okay, subdural hemorrhage, intraparenchymal hemorrhage, cerebral infarct, intracranial infections, encephalitis, cerebral abscess, hydrocephalus, metabolic or toxic causes, drug intoxication, excess ethanol itself causing coma, benzodiazepine overdose, hypoglycemia, ketoacidosis, electrolyte induced mentation changes, hypercapnia induced encephalopathy, hypoxic encephalopathy, post-ictal encephalopathy, post-epileptic encephalopathy, functional psychosis, any other encephalopathy, uremic encephalopathy, and other encephalopathies. So anywhere, wherever there is a decrease in the cerebral function, all of them will come into differential diagnosis, starting with structural nervous dysfunction, subdural hemorrhage, intraparenchymal hemorrhage, cerebral infarct, intracranial infections, encephalitis, intracerebral abscess, hydrocephalus, metabolic or toxic causes, drug intoxication and overuse, either iatrogenic or intentional, and ethanol abuse and benzodiazepine overdose. Hypoglycemia itself can produce encephalopathy, and then ketoacidosis with encephalopathy, electrolyte encephalopathy, particularly sodium, low sodium, hypercapnic encephalopathy, hypoxic encephalopathy, post-ictal encephalopathy, functional psychosis, and other metabolic encephalopathies like uremia and other. Okay. Other important differential diagnoses include epidural hematoma, intracranial hemorrhage, meningitis, salicylate poisoning, subarachnoid hemorrhage, Wernicke's encephalopathy. So what investigations you do?
Blood urea levels.
Yeah. Ammonia levels, blood urea levels, serum calcium, serum ammonia, but serum ammonia is not pathognomonic. Serum ammonia says, yeah, it could be the culprit. There could be encephalopathy PSE in the absence of hyperammonia. There could be no encephalopathy even when there is hyperammonia. Both ways it is possible. That is, it could be false positive, also false negative. But demonstrating high ammonia levels corroborates the diagnosis. Okay, glucose measurements are essential because hypoglycemia itself can trigger the encephalopathy, and aminotransferases, particularly AST and ALT, are done very high AST or ALT, more than 1000 international units, which signifies widespread hepatic necrosis. Sometimes, acetaminophen toxicity can also produce hepatic necrosis, can produce encephalopathy. Okay, appropriate diagnostic evaluations and therapy will be done. However, high AST/ALT values may be observed in other settings like viral hepatitis, ischemic hepatitis, submassive or massive hepatic necrosis, and all that. So we have to be careful in deciding whether the diagnostic test is contributing. So what are the things that came? 1, ammonia; 2, serum calcium; 3, glucose; 4, AST/ALT, and serum AST/ALT are more ALT levels. ALT is more specific from the liver compared to AST, and maybe AST may be released from the muscle, particularly from the cardiac muscle and skeletal muscle. ALT or SGPT is from the liver. Serum bilirubin measurements are essential, of course, to ascertain the hepatocyte function, complete blood cell count to know the degree of anemia and the type of anemia, and blood and urine screening for the drugs essential if it is toxic encephalopathy. Blood alcohol levels are essential. Serum electrolytes have to be done. Prothrombin and PTINR and albumin and bilirubin have to be worked out. This is the lab investigations. And imaging. Supposing I ask you to do imaging, what imaging you do?
MRI brain.
MRI of the brain, CT of the brain. CT is everywhere available. MRI of the brain. These are basically not to diagnose encephalopathy, but to rule out other causes. The purpose of doing CT or MRI is to rule out intracerebral pathology, infections of the brain, meningitis, abscess, tumor, infarct, bleed, subarachnoid hemorrhage, to exclude all those. But there will be non-specific changes in the basal ganglia, the globus pallidus, putamen, and caudate nucleus in case of uh, hepatic encephalopathy. PET, PET scan also can be done, but rarely required to document because there will be evidence of liver disease and encephalopathy. And the reason we have excluded all other brain causes, it mostly establishes the diagnosis. More importantly, psychometric testings are essential to classify the patient as minimal, stage A, B, C, or D is based on the psychometric testing. Several scales are available, validated scales. The psychometric testing is a separate entity. There are what is called the clinical psychologists. If you refer to them, they will do the psychometric assessment and they will document the cognitive disturbance, cognitive ability, and then writing ability, motor ability, speech ability, all those things they will document. EEG also can be done, and sometimes you can do the evoked potentials. Of course, liver biopsy, and then brain biopsy also. Sometimes, neuropathic features of encephalocytis, Alzheimer's type 2 astrocytosis. If you demonstrate and swollen astrocytes with nuclei and marginalization of the chromatin and prominent nucleolus is the type 2 astrocyte, rarely required to do that. Then how do I treat? If he is an alcoholic, alcoholic rehabilitation, alcoholic withdrawal, alcoholic sort of abstinence slowly. Yeah, we have to train him. And as far as the ammonia is concerned, we have said that we will restrict the ammonia by 4 means. 1, gut antibiotics. 2, non-absorbable sugars like lactulose. 3, avoid constipation. And fourthly,
protein restricted diets.
Protein restricted diet and support the renal function to excrete the ammonia. Okay. And we can give probiotics to increase the favorable bacteria in the gut. Sometimes you can use ammonia scavengers which absorb the ammonia, like activated charcoal, which absorbs all gases. And we can use this. Glycerol phenylbutyrate also is a compound, is a prodrug of sodium phenylbutyrate, which is much lower therapeutic doses can be used to absorb the excess gases. Okay. These are some other treatments. Zinc supplementation can help in regaining the liver function. Flumazenil, there is a drug called flumazenil. Flumazenil is a competitive antagonist to benzodiazepines. And we can avoid intrinsic benzodiazepine toxicity if we believe in the hypothesis of GABA and excessive intrinsic benzodiazepines. Okay. To control the extrapyramidal symptoms, you can use dopamine agonists. You can use to control the extrapyramidal symptoms. To treat the albumin, we can give him IV albumin. Can be given to restore the albumin. This is the treatment. Surgical care is possible. Surgical care is Porto-Systemic Encephalopathy. Is a retrospective cohort study has indicated that patients with large spontaneous portosystemic shunts, these are called the SPSs, spontaneous portosystemic shunts, not induced by the treatment. And there, within 100 days of the procedure, 22% of the 59% have been relieved of those symptoms. Diet-wise, we have already discussed the nutrition therapy, what diet we give, what activity we prescribe. Yeah, patient has to be careful. Driving should be avoided in patients with encephalopathy because their mentation fluctuates, and we have to be careful in that. The mainstay of treatment, of course, now to summarize, lactulose, a non-absorbable disaccharide, and gut antibiotics Lactitol also can be used in place of lactulose, which may be better tolerated. Lactulose sometimes produces abdominal distension and gaseous sensation. Lactitol is better alternative if such symptoms are there, but relatively infrequently it is used. Oral antibiotics can be used to reduce the this flumazenil, bromkriptine, and then the branched chain amino acids, L-ornithine, have all been investigated, but they have not shown much of promise. Okay.
Okay, sir.
So all this story is about the rifaximin is also an oral antibiotic. Neomycin is an oral antibiotic, which is locally acting antibiotics. They can be used. Okay.
Yes.
Now, probably you would have had an idea about the Porto-Systemic Encephalopathy, and if you are asked to write an essay on this, you should be able to do that with the information I have provided to you. So because chronic liver disease will end up in Porto-Systemic Encephalopathy, and this is a favorite question for my professor. He used to always ask about Porto-Systemic Encephalopathy. Whenever we have a case of cirrhosis of liver, portal hypertension, he will either ask non-cirrhotic portal fibrosis or Porto-Systemic encephalopathy, and which we have to write and show him either this or that. Not orally telling one or two, there will be flapping tremor, this, that, ammonia, not like that. Whatever I have said, you have to write and show him. Then only he is happy. Last time we discussed non-cirrhotic portal fibrosis. This time we have discussed Photosystemic encephalopathy. I think with this way we have covered most of the liver. Hepatitis B we have done, non-alcoholic fatty liver we have done cirrhosis of liver, we have done non-cirrhotic portal hypertension. We have also done the photosystemic encephalopathy. We did the chronic Crohn's and ulcerative colitis. And what else is there in GI system? I don't know. Ascites in general we have discussed. Maybe tubercular abdomen and maybe causes of lower GI bleeding per rectum. Maybe one other class we can see.
Pancreatitis.
Pancreatitis we have already discussed.
Yes, sir.
Gallstones we have discussed. So these are the 7 or 8 important topics: pancreatitis, gallstones, cirrhosis of liver, non-alcoholic fatty liver disease, non-cirrhotic portal hypertension, portosystemic encephalopathy, and then ascites, causes of ascites and the treatment of ascites. And of course, dyspepsia also we have discussed. That dyspepsia we discussed. And I don't know any other topic. Hepatitis B we have discussed at length. Maybe treatment of hepatitis B and C also can be taken up. Hepatitis C virus, treatment of hepatitis B and C, and then the lower GI bleed and tubercular abdomen. Maybe 4 or 5 entities are left. Maybe one by one we can cover, so that during the course of last few months, GI system has been more or less thoroughly covered both clinically as well as theory wise. Isn't
Yes,
it?
sir. Yes, sir.
Now you write down what are all the things we covered till now, and we will feed it to our HOD also. The GI system, these are all covered, and probably these have to be covered. I will give you review articles on the remaining things, and I will tell you the additional inputs. And this one. Now I'm going to share one article with you, which comprehensively gives photosystemic encephalopathy. And using that, and using the talk which we have now had, you can now write your own words, write around 3 or 4 pages on photosystemic encephalopathy and show me.